Today's webinar is sponsored by Sanofi. The title is Navigating the Insulin Landscape. Our speaker, Dr. Ann Peters, will discuss the fascinating history of insulin discovery and its profound impact on managing diabetes. Dr. Ann Peters is a professor at the Keck School of Medicine at the University of Southern California. She treats patients in Beverly Hills and East Los Angeles and has a strong interest in reducing healthcare disparities for people with diabetes. She has been a PI on multiple grants, has authored over 250 articles and 4 books, and has given lectures around the world. She has been part of multiple ADA, EASD guideline writing groups and was the chair of the Endocrine Society Technology Guideline Writing Group. She has been awarded the ADA Outstanding Physician Clinician Award, the Bernardo Alberto Husse Award from the National Minority Equality Forum, and the Laureate Award for Public Service from the Endocrine Society. We are honored to have such an esteemed speaker, and it's my great pleasure to welcome Dr. Ann Peters.
Thank you, Donna. That was a wonderful introduction, and hopefully you can all hear and see me. But I was asked to talk about insulin, and I think it's a really important topic to think about, especially since everybody's talking so much about another peptide hormone or hormones in the incretin class, but insulin still exists and is obviously very important for people with type 1 diabetes, but also for many with type 2. So these are my disclosures of potential conflicts of interest. And I think we need to think about insulin in terms of what it does. It's an anabolic hormone, so it's necessary for life, and it basically triggers glucose uptake. It makes you make muscle. It makes you store glucose in your liver. It does all of these things, and the pathways and everything insulin does is well outlined in all sorts of articles and book chapters. But really what we need to know is that it works and how do we use it. We also know that the most common side effects are weight gain, hypoglycemia, lipohypertrophy, and edema. And I'm not going to talk a lot about the side effects, except for to say that I've seen a lot of insulin edema in my day if I give insulin too quickly to people with a very high A1C. And I see this a lot in my under-resourced population in East LA, where people come in with A1Cs of 18, 20, whatever they are. And if I give them too much insulin too fast, which is what one wants to do to correct the glucose levels, they'll gain 20, 40 pounds in a couple of weeks, and then they're not happy about taking insulin. So I'm always very careful to bring people down slowly because this is not a sprint, it's a marathon. But as far as when I look at this, I think that the biggest problem with insulin and giving insulin is that insulin is not meant to be given alone. It's a hormone that's meant to be co-secreted with other hormones that balance it. And so whenever I hear about ways to deliver insulin and all these new technologies and everything else, I think it's really great, except I think it'll be even greater when we can actually give insulin with other hormones. And so this is what a normal non-diabetic beta cell or islet cell looks like. And it's filled with all these different colors. And those colors are beta cells, they're alpha cells, they're delta cells, they're cells that co-secrete glucagon, they co-secrete amylin, somatostatin, a number of different hormones. And there's this neural regulation that is amazingly balanced. So in a normal islet cell, there's this group of peptide hormones, there's this group of cells that all work together, and that's not what we're doing when we give insulin from the outside in. And in fact, I think that's another big problem, because all the tools and all the things we're talking about that we currently can do, with the exception of giving people islet cell or beta cell transplants, is all insulin is given subcutaneously. And that's not the way insulin is meant to be given. It's meant to be secreted into the portal circulation. The first pass metabolisms through the liver, and then it goes out into the periphery. And I'm sure this man is well known to all of you. This is Dr. Earl Hirsch, a good friend and colleague. And he's doing a lot of research in a study called dermis, where he's trying to understand what's happening under the skin. And I think that the more that we can understand what's happening under the skin, the better we're going to be at infusing insulin, because everybody knows that one day insulin seems to be working really well, and the next day it's not under very similar circumstances. And part of that is actually what's happening under the skin. We also know that insulin can cause, sorry, my office is texting me, lipohypertrophy. And this is a sweet guy. He's actually a fishing guide who's only had type 1 for 5 years, and nobody ever told him to rotate his sites. And you can see he's only ever been giving it in the very same site and has fairly significant lipohypertrophy. And this is happening with obviously a newer insulin analog, and is making absorption of insulin erratic and difficult. So this is still a problem and has to do with what's happening under the skin as we give insulin from the outside in. But another concern that I have is that insulin, as I mentioned when I started, is no longer the most popular hormone. And this is from Kelly Close, and she looked at the number of abstracts about the clinical use of insulin starting in 2018, going down to the present. And you can see that the number of abstracts at the ADA just has plummeted. There's not a lot of research going on in the field of insulin. There's a lot of research in diabetes, but not in actual making different types of better or more useful insulins, because the hope is that specifically for people with type 2 diabetes, we won't need insulin because we have these incretin therapies. But I don't really think that's true, because I think that people will need insulin, and that I also think there's a subset of people with type 2 diabetes who make insulin less than others. I think there's not just one kind of type 2 diabetes. So I think insulin's always going to be needed for both people with type 2 diabetes and for people with type 1 diabetes until we find a different way of treating it. And along with that, you can see that the sales of insulin, and this is looking at the sales of basal insulin over time, is also really declining. And again, this worries me, not because I want insulin to cost less, I do, but because there's decreasing use. And again, that might be a good thing for people who are now being treated with other therapies. But I always worry about my patients with type 1 diabetes, because I want to be sure that there's enough innovation going on to help those patients as they need to be treated. If you look at the most recent insulin approvals, our last rapid-acting insulin was Lumjev, which was approved in 2020, which was 4 years ago. And the newest long-acting insulin wasn't really that novel. It was a biosimilar insulin to Lantus, which is Semglee, which was approved in 2021. And I'm going to talk about once-weekly insulin, which was presented a couple of weeks ago at the FDA. And just this morning, the FDA, not unexpectedly, said they're not approving once-weekly insulin for type 1 or type 2, at least not yet. And they're asking for a lot of things to be done in order to have the companies obtain approval for that. I also want to point out that once-weekly insulin was approved in places like Canada. So it's available in other countries around the world, just not here. But let's look backward. So the timeline of insulin and the development of insulin really starts in 1869, when a physician named Langerhans described pancreatic islet cells. And then from there, people began to figure out that within those cells contained this hormone that was insulin, and they worked on extracting it, purifying it, giving it to people, first to dogs and then to humans, and then really changing the course of history in terms of our ability to treat diabetes. Now, this slide and a number of the slides that follow with the blue background are thanks to Dr. Vanita Arroyo, who's one of my favorite endocrinologists / diabetologists who's at Harvard, who graciously shared her slides with me. In the 1920s, we were able to actually to give insulin to treat at least what initially was induced type 1 diabetes. And Banting, Best, McLeod, and Collop were the ones who did this research, and this was done in Toronto. And the first mammal to be cured from their diabetes was Marjorie the dog. And you can see Marjorie there with Banting and Best. And what they'd done was they'd pancreatectomized a bunch of dogs, and then they extracted insulin from these canine pancreatic extracts and then gave it back and showed that they cured their type 1 diabetes. In 1922, the first successful test of insulin occurred in a human named Leonard Thompson. And then in 1923, commercial production of insulin began. So if you think about this, this is incredibly quick, right? They figured out that it works in 1921, and by 1923, it's available now for humans to be treated. And it was only a regular formulation. It wasn't something that was an analog. It just lasted like regular insulin, because that's what it was. You injected it, you had to give it multiple times a day, but it saved people's lives. And this shows a picture of a patient named JL. And you can see on the left, being held by his mother, that he's dying. And he's dying because he has type 1 diabetes and there's no insulin available. But he got type 1 diabetes at a really lucky time in history. And he was able to be treated with insulin. And you can see him sitting up looking like a relatively normal 3-year-old child who has been saved because we have insulin. Now, I'm going to step back for 1 second and tell you that even though I don't see people this sick, in East LA where access to insulin and treatment is limited, I see horrible complications from people with type 1 diabetes who haven't been able to use insulin effectively. And so I see 20 and 30-year-olds all the time who are on dialysis, who've had amputations, who are blind. So I really understand what happens if you don't have insulin, or at least not adequate amounts of insulin. So to me, this hormone is in fact life-changing. And now that we have all these amazing technologies, combined with technology, we can really make it make a great deal of difference. And my other caveat is you've got to combine insulin technology and diabetes educators, because without education, people don't know how to use insulin, and it still is a tricky hormone to use. I show this slide not because of these people who get Nobel Prizes, but because they sold their patent rights to the University of Toronto for $1. And Banting said, insulin belongs to the world, not me. And I'm not going to go into the whole sad history of what's happened to the price of insulin over time. But in the beginning, this was one of the most, noble ways of dealing with having a new medication, a new treatment that could save lives. They gave it away, basically. And then others around the world developed it. And this slide shows you the timeline in 1920 when it was first discovered through the present, as different formulations of insulin have happened, different ways of giving it, different ways of making it act longer, act shorter. And it's really changed. And it's changed in my lifetime as a diabetes doctor, because when I started, we had NPH and regular. And I can actually still use NPH and regular with people if they need it. But now I have much better insulins that act more physiologically. Now, on this slide, on the top, those gray boxes look at monitoring and devices. And as you all know, we now have devices that make it even easier to give insulin effectively. It's all still from the outside in, but these tools are much, much, much better than we had in the 1950s, where people were still dipping their urine to look for glucose levels. The first insulin that was developed was an insulin or two that added something to regular insulin to make it long-acting. So the one that I think most of us are most familiar with is NPH, where they added in protamine to insulin and make it longer acting. It's clouding. You had to teach people to mix it up. And I still have people on NPH. I have some people who just love their NPH, and others who use it at night to help with the dawn phenomena, who don't want to go on a pump. But it's still around. I don't know that the Lente series is still around. I certainly don't know of it in this country, but it could be available other places. But in 1936, they added in protamine zinc, which makes it very long acting, and then the Lente series, which further adds in or creates crystals in the insulin, which makes it last longer and longer. Those insulins, though, were either not fully 24-hour insulins, or they were insulins that were more variable. And so then insulin becomes more pure. They begin to reduce the immunogenicity instead of being insulin that is from an animal source. And in the beginning, it was mostly bovine and porcine. It came from cows and pigs. We developed the kinds of insulin that are more pure, that are made in a lab, that are less immunogenic. They have less junk in them, basically. And then we have recombinant human insulin, which now makes it easier to make insulin, and I think is something that helps us help people in a better way, because now these are biosynthetic human insulins. And we have regular at first, we have U500. And I remember when these came out, because it was a big deal in terms of the purity of these insulins and the fact that you could depend on the reaction a person would have to these insulins. Not entirely, but this was certainly, I thought, a big step in terms of people doing better with injected insulin. So then we have insulin analogs, and insulin analogs take that insulin molecule and genetically modify it. They modify the amino acid sequence to do something that allows the insulin to work differently. So it changes how the insulin's absorbed, distributed, metabolized, and excreted. There's a lot of things that go on when you create an analog. And I really have obviously enjoyed this because it lets me further improve the lives of my patients, both in terms of more rapid acting and more long acting insulins. So the first analogs we had were rapid acting insulins. And we first had insulin lispro, then insulin aspart, and then insulin glulisine. And they're not identical in terms of amino acid structure, but they work very similarly. So they have a faster onset of action than human regular, faster time to peak activity, and shorter duration of action. So these are better mealtime insulins. They're still not as fast as they need to be, as we all know, but they're better. There are pre-mixed insulins, which we diabetologists don't really like to use that much because I love to adjust insulins, but I do have patients who will only give 2 shots a day and who need a pre-mixed insulin. And in a sense, they're easier to use because you're not making lots of adjustments on individual doses. But to my way of thinking, they're harder to use because it slaves a patient to a schedule of eating and exercise, because there's a rapid acting insulin and a longer acting insulin mixed together in a fixed ratio. Then we had inhaled insulin, which I'll talk about at the end of this talk, which I think has an interesting role in the management of diabetes. And I have some patients who do great on inhaled insulin alone, and other patients where they use it as a touch-up insulin. But it's nice that we have it on the market. The first form of inhaled insulin didn't pan out, but the one we've had now for 10 years, made by mankind, is actually, I think, quite effective when used appropriately. In terms of longer acting insulin, we tried to get insulins that worked more effectively, that they were more steady. Glargine came on the market in 2000, and in 2005 we got detemir, which is actually being phased out because we have better longer acting insulins. And as you can see on the right, the NPH insulin in purple peaks at about, depends on the person, to be fair. I did some of these clinical trials, but 4 to 6 hours or so after injection. Detemir does have a peak, so it's not truly long-acting insulin in terms of lasting 24 hours, but I've used it actually in athletes who want more adjustability in their basal insulin. And then there's glargine, which is a 24-hour acting insulin, although again, it does have a slight peakiness to it and wears off or starts to wear off at 24 hours. These ultra long lasting insulins, we have U300 glargine and degludec, which I think are truly basal insulins. They last longer than any of the prior insulins. They have less variability and are associated with less hypoglycemia. So these are very nice, very steady insulins, and they're good for people who have steady basal requirements. Then we had the ultra rapid acting insulin analogs. We have ultra rapid acting aspart and ultra rapid acting lispro. And these are insulins that work faster and are supposed to wear off a bit faster. But you can see on the right on that graph, the faster acting aspart, which is in the brick color, and the blue is just plain old aspart. These aren't like wildly different. And the way I look at it is if a patient thinks this works better, it's great because it's probably working better for them, and they're certainly welcome to have it. But if the plain old rapid acting insulin works just as well, that's fine too. I believe people should have a lot of choice when it comes to which insulin they prefer. But to be fair, I've been a little bit disappointed by these insulins because I wanted them to work faster and last less long. So we had better postprandial coverage. But this right now is the best that we have. Then we have this whole field of follow-on biologic insulins, which are insulins that are biosimilar to the existing insulins, and in that regard can be less expensive and they're sort of like generic, but they're not generic. And I'm not going to go into great detail about this. But it's been a little bit problematic to me because the names of all of this are different. So somebody will be put on Basaglar and they'll worry that it's not the same thing as their Lantus. And as a doctor, I spend a great deal of time trying to educate about the similarities of these insulins to the parent compound. And I get it. You don't want to be switched from one insulin to another just randomly. But if they're the same, then I think that's okay. But again, all of this is something to think about and have conversations with patients about. And then in 2021, the WHO really reinforced that people need insulin and that we need to make sure that people who are at risk, who must have insulin, get insulin. And I know this is kind of sad to say that this is in 2021, when 100 years prior we finally got insulin. But it's really been a struggle to make sure that the people who need it have access. And this is part of why I spend half my time working in under-resourced East Los Angeles, because to me, it's just a right. If you have diabetes and require insulin, you should have insulin. It's hard for me to get my brain around the fact that people still can lack access to the kind of insulin they need. But I do my best, and this is just a summary of all the kinds of insulin we have, although it doesn't include inhaled insulin. But you can see we have short-acting, intermediate-acting, ultra-long-acting. We have all of these insulins to mix and match. We have pumps. We have automated insulin delivery. We have all of this in order to try to improve outcomes. The newest insulin that I still think hopefully will come on the market are these two different forms, icodec and this name, which I have so much trouble saying, insulin efsitora alpha, which was formerly called BIF, which are two different kinds of once weekly insulin. And you can see that they're structurally very dissimilar, but they have very long half-lives and they both can be given once a week. Icodec was the one that was presented to the FDA for use in people with type 1 diabetes. Now, in my mind, the beauty of once weekly insulin is either for people with type 2 who are on a once weekly incretin hormone so that they could just give both once weekly shots and get done with it, because I see a lot of people who I think miss their once daily shot, or my patients who have recurrent DKA and other problems who could give a once weekly insulin and have some sort of baseline so that it keeps them safe. Now, this looks at the studies that were done in the Onwards trials. And the Onwards trials were of once weekly icodec, and they compared it to another basal insulin. And basically, you don't need to know all the differences and similarities, but either once weekly insulin was the same as or slightly better than the comparator. And rates of hypoglycemia were almost identical, except in one group, and that's in onward 6. And this is in patients with type 1 diabetes. And in the middle, you see those 2 blue bars, and one blue bar is much higher than the other, the dark blue bar. And that's because in people with type 1 diabetes, once weekly insulin significantly increased the risk for hypoglycemia. And obviously, that's a big problem. And the reason this is because once weekly insulin, at least once weekly icodec, peaks. And this looks at glucose infusion rates in people who are on a glucose clamp. And you can see here that that infusion rate is highest on days 2 through 4 with a once weekly insulin. And days 2 through 4 are where people develop hypoglycemia. So the insulin is most active in days 2 through 4 compared to the other days of the week. And this just shows you the rates of hypoglycemia in that study, where you see days 2 through 4, the rates of hypoglycemia are much higher. The gray is the comparator insulin, degludec. So with once weekly insulin in people with type 1 diabetes, you get this peak days 2 through 4, where someone is more sensitive to insulin because their basal insulin is more potent. It's acting in a way that gives them a higher risk for hypoglycemia. So when this was presented to the FDA, to the Metabolic Drug Advisory Committee, the advisors voted 7-4 against approval. And as I mentioned, as of today, the FDA basically sent them a letter saying that this insulin is not approvable at present, but there needs to be more work done. And it was felt that this was due to this increased risk for hypoglycemia in people with type 1 diabetes and a difficulty in mitigating the risk, because you'd have to give different doses of rapid-acting insulin days 2 through 4. And I think that's really hard to do, to count the days of the insulin dose and everything else. There's concerns about what would happen if somebody was an inpatient on this insulin, and how would you dose insulin in the hospital if you don't have once weekly insulin available. And interestingly, in the clinical trials with type 1 diabetes, there was no improvement in patient satisfaction, but they're already giving lots of daytime injections as it is. And this just didn't seem to work as well as one would have liked in type 1 diabetes. But I'll show you my dream. So this is AGP and a patient of mine in East LA. You can see how high their glucose levels are. It doesn't really take somebody who's a genius at figuring out data, because this person's target range, that green level, is only 15%. And otherwise, they're just high, but they're also a little bit low. And their average glucose level is 285, and their GMI, which is an estimated A1C, is 10.1%. Now, this is something that looks like this. And what you can tell, or at least I think, is this person is erratically giving insulin. And I think that they're supposedly on Lantus and pre-meal Lispro. But I think that here, and maybe a lot of other days, they're missing their Lantus dose because they're just so high and nothing's changing. And then other days, I think they are giving their Lantus. But for instance, here, and here, they're giving so much Lantus that their glucose level falls. And Lispro. So what's happening is that they're giving insulin erratically, and their experience of insulin is not good because they're either way high or they're low. And what I'd love in this person, in my dreams, is to be able to give them a once weekly insulin. So I know they're getting some insulin that keeps them out of DKA, and just keep their blood sugars at baseline at 180. And so it will flux days 2 through 4. That's fine. They'll just be around 180 or a little bit lower, a little bit higher. And then have them give little tiny doses of rapid-acting insulin before meals. And I think that could actually keep these patients safe. And sure, it's not going to get their A1C to 6.5, but it might get their A1C to 8. And that might be a lot better for them than an A1C of 10 or 12. And these are patients who come in and out of the hospital all the time in DKA. So I still think that there's a role for once weekly insulin in people with type 1 diabetes, but We have other technologies and other ways to really fine-tune type 1, but still, this is what I think of when I think of once weekly insulin in that population. Then I'm just going to touch on the InHealth 3 study, which was a study that was presented at the ADA this June, which took people with type 1 diabetes on any therapy and randomized them to either being on degludec plus inhaled insulin or whatever they were on, standard therapy. And they could be on automated insulin delivery. It was a 17-week trial. Both arms were on CGM. And at the end of the 17 weeks, there was a non-inferior change in A1C. So this switch didn't change A1C. It didn't worsen it. It didn't improve it when you look at averages. But if you look at the actual individuals, and these are just approximations because you can read the abstract for the full details, but about a third of the patients on the inhaled insulin group got a lot better. Their A1Cs came down to less than 7 versus 17% of the usual care group. And these are patients who started out with a higher A1C. So in about a third of the patients, they did really significantly better. But 21% of those on inhaled insulin did a lot worse. Sorry, I'm lying. The second line is the 21% who got a lot better. And the a lot better was if their A1C started higher. And then 26% of the patients on inhaled insulin got worse compared to 3% on usual care. So the way I look at it is this is an insulin that can actually help a certain subset of people, but another subset of people did worse. And this is like all things in diabetes. It depends on the individual and what they need. And you can do better on inhaled insulin. This is a study, there were study coordinators, people were taught, they were followed. And one of the things that they found was that people needed more inhaled insulin than they thought. So that dose conversion of inhaled insulin being 4 units means 2 injected units may not be right. And these people tended to need even more than that to bring their sugars down. But regardless, if somebody wants to try this, I certainly work with them and have them take the insulin and dose it appropriately. And that often means giving a postprandial dose as well as a preprandial dose. But this study, I think, was good in the fact that it showed benefit is possible, but it also shows that it's not going to be the right insulin for everybody, and that there would be patients who didn't do better if they were put on inhaled insulin. And finally, the one thing I want to touch on is that I think insulin, for all of its wonders, has ended up causing a lot of us, both patients and providers alike, a great deal of distress. Why does it cause distress? As we've talked about, it's a hard hormone to use. There can be highs and lows. There can be all sorts of issues. But I think that the real issues with insulin anxiety that none of us should have to do with cost, supply chain issues, and concerns over which type is the best for an individual. And I get this all the time. First, that the insulin I want to give someone's too expensive and I have to do a prior auth and I can't get it for them. And they're all frustrated and their insurance is changing the type of insulin and I need to do a prior auth for the old type because the new type doesn't work as well. And all of that makes getting insulin a hassle for all of us. And then there's these real concerns about supply chain because now all these companies are making incretin hormones rather than insulin, and insulin isn't the moneymaker it once was. So I feel that as a diabetologist, I have to really worry about all of these issues for my patients. And I think patients unnecessarily have to worry about these issues too, which is why I think it's really important to understand each individual and what they need. I think it's important to understand the different types of insulin. But I do think incumbent upon us, meaning medical professionals, it's very important to help patients understand all of this. My dog's about to bark for unclear reasons. And really work on making sure people have the insulin of the type they need at an affordable price and have that insulin be readily available. So we go back to the beginning of all of this, which is that historically insulin is a wonderful drug and it's been fraught with certain issues that I think shouldn't be there for insulin, for a drug that is life-sustaining. So these are my conclusions, which I've just pretty much stated. Insulin is challenging. I think that now we have all these newer devices and technologies. We're better and better at using it. Patients are having better outcomes. but it's still not easy. There's still concerns about cost, access, supply chain issues, changes in type. And I still believe that we're far from, but hopefully we'll someday have stable, universal access to affordable insulin, and we'll be able to help our patients the way they need to be helped. And I can't stress enough the need for diabetes educators in all of this, because even when I can get patients insulin at an affordable rate, I still often can't get them access to education. And that is another thing that makes me slightly crazy. So with that, I and my team will say thank you, and I'll stop sharing, and I'll take any questions that you might have.
Thank you, Dr. Peters. A great presentation. And we do have some questions. The first question, hang on, I'm going to pull up the question.
Just a second, I'm letting my dog out of the room because she didn't.
Okay.
Sure. Okay.
Okay.
It upset her.
The insulin talk, huh?
Uh-huh.
Oh my gosh. Okay, the first question comes from Anne, and she said, how to keep my weight down. I'm type 1. I'm on 1 dose a day, 16 units. Doesn't say what kind, but I'll need pre-meal soon, so it must be long acting. I'm concerned of weight gain. Over the years, I've lost about 65 pounds, and I'm a good weight now, but want to keep my weight down.
Well, congratulations on doing such a good job on your weight. And first of all, people don't have to gain weight when they advance their insulin therapy. But some people do, many people do, because of 2 things. One is, again, because it's insulin given from the outside in, so you're always having a higher circulating insulin level, and that can cause highs and lows. And people often will eat extra for the lows, and when you have to eat extra for the lows, you put on more weight. And then insulin itself is trying to help you gain weight. It's helping you keep weight on your body. It's part of what it does. So that several ways to do that. One is that sometimes going on an automated insulin delivery system is helpful, because if I have people, say, on an Omnipod 5, I often don't see much weight gain because it's delivering insulin without causing quite the variability that you might see on just shots. So I've helped people that way. The other thing to do is a low dose of incretin hormone, either semaglutide or Mounjaro, which is tirzepatide. Now, you would say maybe that you have type 1 diabetes, but I would say that I can't tell whether or not you have type 2 diabetes as well. So I always just double code everybody for type 1 and type 2. And it says in the ADA standards of care that we can no longer clearly differentiate between type 1 and type 2 because it's too overlapping. Because you can have antibodies and be a type 1, or antibodies and be a type 2, or no antibodies and be a type 1 and no antibody. It's all mixed now, because when you look at it, it's really hard to tell. So if I double code people, I can get them to be on incretin hormone. And like I said, I generally start out with really low dose semaglutide, and just a couple of clicks, even just up to 0.25, will help. It's sort of like giving you back physiology, because it's an incretin hormone, which your body's supposed to be releasing in response to insulin. And I can keep people's weight pretty steady that way. So I'll mix and match whatever I need to do to keep people at their targets.
Great suggestion. We have another.
Wait, just going to tell you just one thing. That's actually
Sure.
off-label advice and on-label advice. Because if my advice is that I think you're both type 1 and type 2, it's on-label. If I'm saying I'm giving it to you because you're type 1, it's off-label. This is things that doctors have to think about. But I'm telling you, I think you're both. You have to be both. How can I know? So I just give you both codes, both treatments.
Good suggestion. This kind of goes along with it. I have a problem with it comes from Deborah, I'm sorry, and she doesn't say where, but I have a problem with being constantly hungry after 12 noon and eat. My sugars go high in the 300s between 12 and 3 p.m. Any suggestions on how to curb my hunger and keep my sugars down?
Well, so an incretin works. There is one that's approved for use in type 1, which is called Simlin or pramlintide, which you can actually give along with an insulin dose that does help curb appetite. And you could conceivably get that on label and give it before lunch to help make it so you're not hungry in that window of time. You know, I don't ever think hunger is a negative thing, oddly. Hunger is what we're meant to have, right? We're meant to be hungry, so we go out and kill wild animals and eat them. So hunger is a complicated phenomena in our bodies. And when you give someone insulin, you stimulate that hunger. And it's not the same, and it's not the same given the time of the day and everything else. So it's almost like your body isn't doing something abnormal. Probably when you give someone an insulin shot, they're supposed to feel hungry, but you don't give it with another hormone. And so amylin, which is Simlin, is another hormone that helps, but it's hard to give because it's relatively short acting, and giving, again, a low dose of a drug like semaglutide can really help that hunger.
Okay, this comes from an anonymous attendee. It said, "This isn't a question, but a thank you to Dr. Peters. Choice is so important in insulin and its delivery. As a person with type 1 for 33 years, I've used a lot of different insulins with varying success. Currently, Tresiba, Humalog with the InPen, and Afrezza is a good combo for me. After 20 years of using a pump, I had some absorption issues and needed to move back to MDI. Keeping stable blood sugars is constantly a moving target for me. Thank you so much for advocating for insulin choice and for serving populations that struggle with access and choice."
Well,
It's nice.
thank you for that. But what I have to keep saying again and again is never let someone tell you that they know better than you. And I get these patients who come to see me who say, my doctor says I have to be on a pump, or my doctor says this, and my doctor says that. And it's so weird to me because the doctor isn't wearing the pump, or the doctor's not giving the friggin' shots. The person is with diabetes. And if you don't have a healthcare provider who listens to you, and if you have a healthcare provider who pushes you, you need a different person. I'm not joking, because this is not about the doctor or the healthcare provider. It's about you. So I can't say that strong enough, because I get so sad when I see people who I feel like were mistreated by the medical system because somebody pushed their agenda on somebody. And that's not, as you well know, how to treat type 1.
Absolutely. Very good. Okay, we have a question from Janet. It says, "I've basically been a sedentary person all my life, but I know that exercise is very helpful in managing type 2. Can you give a pep talk about how little exercise, like a 5 to 10-minute walk around a New York City block after meals, really is?" I guess she meant really is good. That's what I'm thinking she means.
Well, so it's good not only for diabetes, but for your health. So there's a lot of stuff that just matters. So it matters to all of us, diabetic, someone with diabetes or not, to eat a more plant-based diet. That's just good for you. And exercise is just good for you. And I personally hate exercising, but I force myself to do it because I love hiking. So you have to think about a reason why you're exercising. And it is a good reason that it will lower your blood sugars. And remember, there's two ways your blood sugars go down. One is mediated by insulin, and one is not mediated by insulin. It's called non-insulin mediated glucose uptake. And so when you walk, your muscles take up glucose, and it's kind of like a sponge. You can actually, another flip side is you can go too low with exercise, but that's an entirely different lecture. But you really want to get your muscles to just pull in glucose, and that way you don't have to give as much insulin. That way it's so much healthier for you, and that way you're getting exercise. And it only has to be 5 or 10 minutes, but you've got to do it in a way that's really easy. So you can't make it so that you've got to get all dressed up and go outside and, it's cold or hot or whatever in the heck it is. You've got to make it really, really simple. And I don't care if it means going up and down stairs a bunch of times. Whatever it is, do it in a way that's so accessible, there's no excuse not to do it. And I just keep in my brain list, and, every week I have to do 5 times sessions of higher intensity interval training. And I just count every week. And if I'm not at 5, I force myself. I just have a counter. And I've made this commitment. I've done it for my whole life because it's something even in medical school way back in the old dark ages at the University of Chicago. I knew exercise was so vital to health. And it's not just for people with diabetes, it's for all of us. So I'm not really picking on people with diabetes.
Okay, we have 2 more questions, so we'll answer them really quick. So this comes from Karen. Is there a way to deliver insulin deeper in your body, closer to the liver and not sub-Q?
Not yet. There are insulins that preferentially are supposed to go to the liver, and a couple have been under development, but the problem is that it hurt the liver. And so it's very hard to do that. The obvious way to do it is to give beta cells, the stem cell derived beta cells that Vertex is working on. And by disclosure, I'm on their scientific advisory board, but they actually put those beta cells with a catheter into the liver. And that's where they work. And they do work. It's a question of whether we can get them to work without giving immunosuppressive therapy. But it's really cool to watch this work. So that my hope is, that the research has never been more active in terms of looking at how to either treat or cure type 1. I don't know that it's going to be a cure, meaning it's going to go away forever, but I think there are going to be some cellular therapies that work to treat it, that maybe once a year you get an infusion and you're fine. I don't know, but I'm more optimistic than I've ever been.
Very good. And the last question comes from Debbie. I'm on basilar and VS injections after wearing an insulin pump for over 20 years. My A1Cs have been in the 6s, both on a pump and off. My ups and downs are constant. Every night. I'm finding the older I get, she's 60, 43 years with type 1, and I pre-bolus before meals, but always go high, then come down. What can I do to help my insulin injected?
The problem is that it sounds like you may be at the limit of what injected insulin does. You know that insulin is harder to use as you get older. Probably the subcutaneous tissue is tired. I don't know how to put it any other way, but Earl's doing a lot of research into this. But it's very hard to use injected insulin, I think, because of all those timing differences. And the more consistently you eat, the more consistently you exercise, all of those simple things will help it. Or I have a lot of my seniors actually going the Omnipod 5 system just because it takes that little infusion set seems so much easier. It jiggles less, I think, than other infusion sets. And so I've seen a lot of success that way. But that postprandial rise, we're never going to get that better. It's just hard to do. And I think that the problem with insulin is once you've given it, it's in your body and you can't take it out of your body. So there's no break. So you're always giving it up front. And some of these systems, the AI and the newer automated insulin delivery systems is getting smarter and smarter, but it still can't do it like a non-diabetic pancreas because it doesn't have all those different hormones in it. So it's hard to do, but I think it sounds like this person's doing all the right things with timing, dosing, consistent, insulin delivery, food that's pretty standard. So it's just hard. I'm just telling you, I empathize. But yes, and I now have a patient waiting for me. So
Okay.
goodbye to all of you sweet people. And it's really good to talk to you this morning.
Yes, and thank you for all your questions, because we definitely are out of time. And again, Dr. Peters, thank you for a wonderful presentation.